The on-off switch, an important thing to learn early on. Um, and I'll ask people as you come in to kind of come forward. We know it is a super rainy, soggy night, and I think people will be kind of making their way in over the next few minutes, and so we want to leave room for them as well. We are also, as you may have heard from my colleague Rick Davis, live streaming this to about 40 people who we know are on with us now. May they be dry and warm. May you be dry and warm, people watching from your offices or at home. But it is a great pleasure and privilege to welcome all of you here tonight. My name is Diane McGillivray, and I'm the Senior Vice President for Advancement at Northeastern University. This Women Who Empower series, which is the outgrowth of a program that we began just 3 short years ago called Women Who Inspire, is something that is really special and important and personal to me and the people in our division, which includes alumni relations and outreach to our various communities, Northeastern communities here in Boston, across the nation and around the world. And as we built this series and brought people both to our campus and then to other sites around the country, we really discovered that there is a great desire for a platform and a program like this where we can come together and hear from people who give us lots of inspiration and lots of ways to think about how we can connect with one another and move forward in our lives and our careers, networked together. So I mentioned that this series started 3 years ago. Tonight marks our 20th program, if you can believe that, in just 3 years. So thank you to all of you, really, for participating and making it possible. Last week, we had an inaugural Women Who Empower Summit. It was a full day of dialogue and hearing from women who are empowering other women by what they do in their careers, and empowering not just other women, but empowering their businesses, empowering their communities, and really doing so much to advance all of the sectors that they're in, whether they be for-profit or nonprofit. And I have to tell you, I said this was a personal series for me. It was an interesting experience to be surrounded by 150 outstanding women last Wednesday, after an evening that had been really surprising for all of us and distressing for many of us. And we discovered that it was in that room and in that dialogue, no matter what our points of view were, or how we felt, that we really agreed that what we're here to do at an academic institution is to think about the future. And we have such a great privilege to be in a situation where our stock in trade is optimism and hope and education and making an impact and leaving our communities and our world a better place. So I can think of nothing better than to extend what was started in that dialogue last Wednesday to this evening with a speaker who is really, really terrific. I like to say that a great university is a collection of great stories. As we've had our Empower campaign roll out over the last 3 years, we've also been able to hear from so many of our students, our faculty, our alums, to hear their individual stories. And they've all been meaningful and powerful in their own ways. I also believe, though, that it is in the sharing of those individual stories that we come together and network as a community, because in that sharing of the stories, we engage and inspire and, yes, empower and definitely elevate one another. So tonight, I'm really honored to be able to introduce a special friend who does just that. She empowers and inspires and elevates. A speaker so good that when she was here last time at one of our series, we were left in awe of all that she's accomplished, and we asked her to be with us again. Dr. Vanessa Bradford Carey holds degrees from Yale, the London School of Economics, the London School of Hygiene and Tropical Medicine, and Harvard Medical School. Maybe I shouldn't say this, we'd like to say perhaps as importantly, she holds a degree from Northeastern University as well. In 2015, Northeastern awarded Vanessa an honorary degree in public service, and it was great to be with you on the stage that day and to see you honored for the work that you've done. A mother of two, Vanessa still finds time to work overnight shifts in the critical care unit at Mass General. She has a passion for medicine, an exemplary commitment to public service, and a laser focus on finding sustainable solutions. So things that go beyond today or tomorrow that have impact for generations to come. But it is Dr. Carey's entrepreneurial spirit that fueled her true calling, Seed Global Health, a public-private partnership she founded in 2012 with the Peace Corps. Seed focuses on training health professionals in the developing world and has made an enormous impact on sub-Saharan Africa, and you're going to hear more about that this evening. Dr. Carey will be joined on stage tonight by Dr. Carmen Shepa, professor and chair of Northeastern's Department of Health Sciences. Carmen's research targets vulnerable populations, including those of the underserved, frail, chronically ill, and ethnically diverse. So improving human health is one of the most important things that we can and must do for our collective future. So please join me in giving a warm welcome to two women who are doing just that. Thank you.
Thank you, Diane. I want to thank President Ayoun and all of the Northeastern for the opportunity to come back again. It was such an incredible honor to get that degree a year ago. I mean, I was speechless and very, very humbled by it, and hope to live up to what that degree means. And so I thank the community for that very much. Before I get started, I want to take a moment to also just acknowledge some folks who are part of this story that we're going to tell. Dr. Eileen Stewart-Shore is here. She's the Chief Nursing Officer for Seed Global Health and has really been, in the year plus that we've had her, an extraordinary champion of what it means to really change how education is viewed in all health professions, but especially in nursing. And I've learned a great deal from you, so I'm honored that you've been a part of our team. Janet Dewan's here, and she actually is part of the Northeastern community. She has helped support one of our volunteers in the field who's been doing nurse anesthesia in Liberia. And actually Mary O'Sullivan, who's a nurse anesthetist in Liberia, I just learned, got her DNP here. So she has been involved in the community as well. So Northeastern is part of this journey and story and what's happening. And I'm just grateful that you took the time to help get her up and started and have the impact she's had. And, and we'll come back to Mary a little bit later. And then Megan Carroll is here as well, who basically keeps every single piece of Seed running single-handedly. So I'm very grateful for Meg's support also. So I thought what we'd do tonight is just start a little bit. I was just going to introduce to you sort of what we do, the problem that we're trying to solve, and then really what I think is going to be important is that we have a conversation, because we're at a very interesting moment of time, regardless of what your politics are. A lot of questions that are being asked, and I think that relates very much to what we do. And I think it's a lot of, when we talk about how we get engaged in our communities and how we move things forward, will be, part of that discussion. So I don't know if I have a slideshow up yet. So I'm going to show some slides. I'm not going to be wedded to them, but I think sometimes it can be helpful, one, to keep me on track, but two, just to sort of see a little bit about what we do. So it should be called NEU. I don't see it up there. All right. Is the thing in? So I'm just going to start talking. So one of the things that we sort of, when we talk about global health, I just want to take a moment and ask everybody in this room, who here thinks they can define global health? I never, ever get a hand. That's not fair. I've had 2 hands in 6 years of asking that question. And one person actually, raised their hand and said, well, it's everything having to do with health for everyone. And I was like, that's actually like the most succinct definition of global health, because at the end of the day, global health is exactly that. It really doesn't define anything. Oh, it's my overview. We'll skip it. So importantly, when we talk about the realm of global health, there's no standard definition for what global health is. And global health has very interesting historical roots when you think of it as a field. It's really rooted originally in tropical medicine. This idea in the late 1800s that there were folks going to Africa or South America as part of industry and they were dying of diseases. And so these colonial powers said, well, we're going to send doctors and other health professionals and nurses to take care of our workers who are dying. And then people said, well, looks like there's a lot of other medical problems here. I'm going to go to this other country and I'm going to deliver health in that other country. And then I'm going to come back home. And there's a really dichotomous view of a them and then an us. And then the field sort of evolved into what we now define as global health, which is this idea that there are health disparities or health issues that exist in the world that maybe aren't as well defined as an us and them in the way that we define, in the way that was traditionally used. And so when we think about that, the best definition that I have seen is not clean. It's a Lancet article from 2009 where a bunch of folks came together attempting to define global health, and the best that they could do was boil it down to these 5 points, which you can read for yourself, but basically is the idea that many countries or transnational issues can be determining this problem. It is a scope of problems that is not defined by geography. It is not like malaria hits the border of Rwanda and says, oh, I'm going to stop here. These things can kind of keep going. It's really complex interactions between society, right? So the water issues that come out of Uganda and Ethiopia will actually define some downstream problem potentially in Egypt in terms of health or wellness that matters very much. It's going to take a diverse group of people to try to solve this problem and a diverse series of resources to solve this problem. And I think very importantly, it also spans the entire health spectrum. We could be talking about prevention, we could be talking about treatment, we could be talking about research, we could be talking about administration, any aspect. That's global health, right? I just took 5 minutes to get to that definition. It's not neat and tidy. But the beauty of that means there are many, many places that people can intersect. And that's the biggest piece I want you all to take away from tonight. So it turns out that health actually exists at many, many levels. We talk about public health, sort of the health of a population, and we think of schools of public health that are addressing those issues. There's also health systems. That's a big fancy word that we talk about more and more. What is that health system or health ecosystem that is part of health? So to speak to health systems specifically, because this is kind of the hot, sexy new word on the street, we're going to strengthen health systems. What does that mean? So the World Health Organization breaks health systems down into 6 fundamental building blocks, which could be governance. So who's running the health system? Is it a Ministry of Health? What are the laws that we passed? Do we have universal health coverage? Who are the human resources, the people actually making up the health system? How is that health system financed? Is it single payer? Is it pay out of pocket? Do you have insurance schemes? What are the products and technologies that go into health? The medicines, what is the information and research? How are we, tracking things? How do we use this research? And finally, what is the actual service delivery? What does it mean to be a physical therapist on the wards? What does it mean to actually be a nurse delivering care and in the setting that you're in, or a doctor making those decisions? And so various aspects. So when you look at this, there's a lot of places to try to intersect and solve a problem. But it helps to focus, at least that's my new motto. And so I'm going to skip this part and just go to the next thing. So what we have attempted to do was we sort of asked ourselves, what is a big problem that we don't think anybody else is thinking about? And there's a backstory behind this, and we'll sort of talk about how we came to this. But there's a realization among my colleagues and I at SEED that nobody was really focusing on human resources for health. People were addressing technology. You have, electronic health records going into place, products and technology. Billions of dollars are spent developing drugs a year. You have people thinking about governance, in terms of how you're going to orchestrate a health system. Plenty of people training doctors and nurses and thinking about those problems, or some people training doctors and nurses, but we felt like globally that issue of human resources was not being addressed enough. So in 2006, the World Health Organization issued their World Health Report on this exact question. And for me, this report kind of boiled down to this single graph, which is very intuitive, yet somehow nobody quite seemed to be really trying to dive into the space. And so if you look at this graph, on the y-axis, you have probability of survival, and on the x-axis, you have density of health workers. And it turns out the more healthcare workers you have, the higher the survival of a population. Shocking, right? Well, turns out that when you actually put this to paper and you diagrammed it, people suddenly went, wait a minute, we're not dealing with this exact issue. And so suddenly people started to ask, how are we going to address the human resources for health? And it turns out that today there is a critical shortage of 7.2 million doctors, nurses, and midwives in 83 countries around the world. And that critical shortage is slated to actually increase to 18 million basically over the next 20 years. So this is a problem that is not getting better. It is a problem that is only about to get worse. And the geography of this problem is very focused in a few areas. And if you know, and those are the countries that are really in red. And it turns out that if you map sort of the economic indices of these countries and GDPs, it also looks a lot like this particular geographic distribution. And it turns out that unfortunately the global burden of disease is worst in those countries that have the most critical shortages. So if you take sub-Saharan Africa, 25% of the global burden of disease is in sub-Saharan Africa, yet there's only 3% of the world's healthcare workforce trying to address that exact problem. And if you break it down to expenditure, only 1% of the world's health expenditure is in sub-Saharan Africa. That is a major disconnect between what needs to be addressed. What does this disproportionate burden actually look like when you talk about specific diseases? So mapped here in blue is the global burden of HIV, and 97% of those living with HIV reside in low or middle income countries. When you map it to non-communicable disease, 80% of all non-communicable disease deaths are now in low or middle income countries. And when you map it to maternal mortality, 99% of maternal deaths are in resource-limited countries. So that's really real numbers, but that's also really real opportunity. And that's the big thing that I want to talk to you about tonight. One of the things that is driving this critical shortage specifically is some phenomenon called brain drain, which is the idea that you train folks and they end up leaving these countries with the critical shortages. And you can't fault them. They practice to be a gastroenterologist, but they don't have scopes to do that, to do the work that they want to do. They don't have the skilled nurses to help support them in the field. The nurses want to be able to take vital signs, but they don't have something as simple as a blood pressure cuff, or they don't have professional development opportunities, or they don't get trained in wound care. It's very difficult to want to continue to work in these resources when you're constantly having a total, emotional and psychic state challenged by watching patients die day in and day out by very preventable things. There's also a phenomenon of internal brain drain in these countries. So it's not just that folks leave their countries. They might leave to go work for NGOs. I have our name up there because at the end of the day, we have 3 outstanding country representatives who technically were once part of the clinical workforce. Now, we hired them long after they had left the clinical workforce, which was sort of an important appeasing principle. But one could also say that's a little bit like saying that you're taking a blood diamond just, 2 owners later. But we have to recognize that this is a really real phenomenon that is part of what exacerbates exacerbates the problems that we're talking about. So what did we try to do about it? What is the history of SEED and the problem we began? So the long story short is that this problem was identified and many people felt that maybe there was an opportunity to gather the great interest in global health in this country and start to put it to work towards a specific problem. And if you look back in history, the Peace Corps actually was founded on the very idea of sending health professionals in service of America to help improve and teach and train in another country. And so President Kennedy actually asked in his impromptu speech on the steps of the University of Michigan at 2 a.m, who of you, who are going to be doctors are willing to spend your days in Ghana? The same would apply to nurses or physical therapists or other technical specialists in the health profession. Well, if you flash forward quite literally about 50 years to 2010, there was a celebration during the 50 years of the Peace Corps' 50th anniversary that had a forum at the Kennedy School of Government. And the 4 living Peace Corps directors all were part of this forum there. And so we went to this forum as public citizens, and we raised our hand at the end of the public forum and just anonymously from the rafters asked, what do you think about the Peace Corps sending doctors and nurses abroad to be educators, to teach and train and to build capacity, and to provide a new professional diplomatic corps for America? And the director at the time, Aaron Williams, his answer was yes. He thought it was a great idea and something Peace Corps could do. So we used that as an opening. We introduced ourselves. We outlined a sound premise. We said, just give us a chance. Let us come to Washington and talk to you about this idea. And it turned out it fell at a really great time, because in 2008, the President's Emergency Plan for AIDS Relief, which was the big multi-billion-dollar effort started under President Bush to help deal with HIV/AIDS and to put people on treatment, realized they couldn't put people on treatment, keep them on treatment, and deal with the complications of treatment, or deal with this population of patients that suddenly was living longer, but developing heart disease, developing diabetes, developing kidney failure, and all these problems that come from HIV or from the medications themselves, unless they had skilled health professionals and people to start to deal with that population. And so they realized that they were going to have to start emphasizing teaching and training of healthcare workers in order to fix this. And they set a goal of 140,000 healthcare workers, but they had no idea how they were going to do it. So it worked out really well, because suddenly Peace Corps said, hey, wait a minute, we've got a plan to train these healthcare workers, but we need funding. PEPFAR, you have the funding and you have no plan. And what was born was a public-private partnership between Seed Global Health and the Peace Corps in a program we call the Global Health Service Partnership. And so this is Seed's flagship program. We do work outside of this program now, but we started with this fundamental idea that we would send American healthcare professionals as clinical faculty. They were going to live there for a year. They weren't going to fly in and fly out, but they were going to spend time in the community. They were going to build trust. They were going to go to weddings. They were going to go to funerals. They were going to learn the language, and they were going to understand where they were, and they were going to stay for a year so that they could see an academic cycle through and teach and train and really have an impact. It enhances existing clinical training systems. There are outstanding faculty and students there who just need an opportunity to thrive and to really have the opportunity for professional development. Our volunteers are fully trained doctors and nurses. We're not sending students. We're sending people who have experience in teaching and training so they can have an impact. How does it work? So we partner with ministries of health and ministries of education. We ask them what their needs are. They point us to sites, and then it becomes like a dorky online dating game where one of our volunteers comes with a specific specialty. We match that specialty to what the needs of the sites are, and then that volunteer, the site gets approval for the volunteer. We want their voice in this, and then the volunteer will go and spend a year there. What we do that is unique to every other organization really is that we focus on education and training, and we do it following our country's leads and priorities. So we don't come in with our methods or curriculum. We really go and partner to understand how we can enhance what is existing. What does this look like? So in practice, we currently now are at about 22 sites partnering with 17 institutions in 5 countries. We started in Tanzania, Malawi, and Uganda, and these are countries with some of the worst shortages of doctors and nurses. Tanzania has 24 nurses and 1 doctor for every 100,000 people. In the United States, that ratio is about 980 nurses and 240 doctors for the same population. So it's incredibly different. So 1 for 100,000 versus 1 for 420 here. So really, really dire shortages. In a place like Liberia, there's only 43 physicians. And Eileen, what's the count on nurses? Do we know? I don't even think anyone's ever tallied it, which is another thing that we're going to talk about is the disparities in the health professions and where they are. And so this is where we are now. What this looks like is we now have in year 4, 71 volunteers in the field, 10 of which are actually returned Peace Corps volunteers. So we're seeing Peace Corps volunteers who became health professionals who want to go back and apply their skill into the field. GHP SP extensions means that these are people who served a year and then re-up to serve a second year. So 1/3 of our volunteers this past year decided to stay on for a second year. And we've already heard in our 4th year about 10 people who want to re-up. And this is early, and we're already hearing this. And then the one thing that I didn't mention yet is that one of the big things that SEED does to help this program actually exist and thrive is that there's no federal mandate for loan repayment for international health service. So we have this wonderful program called the National Health Service Corps, which supports you to serve domestically and helps repay your educational loans. The average health professional graduates with $170,000 worth of debt by the time they have finished all their training, and that's going to public institutions. That's very real when you want to make a choice to go into service. So SEED is committed to providing up to $30,000 of debt repayment for each year that you serve. We'll cover educational loans. We'll cover your mortgage. We'll cover whatever is your barrier to service because we feel it is so important to have this kind of engagement in the United States. We have sent a range of specialties. I'll let you look for yourself, but we will send everything from pediatric critical care nurses to orthopedic surgeons. So it's a real variety. There's certainly core areas that we focus in, like internal medicine, pediatrics, OBGYN, and family medicine, or women's health and nursing, community health and nursing. But we have a whole range depending on what the need of the sites are. Our impact is that we really are helping to strengthen nursing and medical education. We do believe this is a contribution to health system strengthening because if we can help ensure that there is a highly qualified, high-quality, well-trained workforce that sees the power of what they can do, that they want to stay and continue training, that's a really real investment. We think it's a new face of diplomacy, and we think it can be a low-cost, high-yield premise if we really maximize what we are doing in terms of partnering with like the Peace Corps, taking advantage of their economy of scale, or partnering with an academic medical center to really potentiate their contributions, that we can make this cost effective. It's also investment in our country. So we know that folks who work abroad are more likely to come back with skills that can be applied here. 47% of our volunteers are involved in education in this country now, and an additional 30% are working with underserved or at-risk populations. So this is a very real contribution into our health system as well. I want to end with 2 quick stories for you, just to frame a little bit about what we do. So one of our midwives who went to central Tanzania, Mary Godert, basically told us a story of how she, was seeing babies die. She was prepared for that. But there was this one day where she came on the ward and she saw a newborn child that was alone, cold, dehydrated, and effectively dying. And she freaked out. She asked where the mother was, and she found out that the mother was on another ward with this child's twin. And the mother had to make a decision, basically, because she couldn't care for 2 children. And she was so upset by this. She was running. She gets milk from the mother. She gets a blanket. She runs back to the child, and the child has died. And she's completely distraught by this, understandably. So she asks her colleagues for guidance because they clearly have dealt with this situation before. And she says, tell me, I don't know how you are able to deal with this day in and day out. What is it? What are the tools that you use to deal with this? And one of her colleagues, her Tanzanian colleague, says to her, it's God's will. And Martha says, okay, all right. And she takes that and she holds on to it for a couple more weeks. And then she wakes up one morning and she says, wait a minute. I got it. She goes back to the wards and she looks at her colleagues and she calls them around. She says, you know what? We can be agents of God. And today, basically, or effectively is what she was going to say. But she goes to them, she says, today it is God's will that no child dies of hypothermia or dehydration. And no child did on that day. And it was an empowering way for the community to understand how maybe they could be able to fight against sort of what has felt to be the status quo and they've been forced to accept for so many years. And it's not perfect, but it was an ethos change that helped shift what happened. Mary O'Sullivan, your nurse anesthetist, our nurse anesthetist who's working in Liberia, wrote this really beautiful email back saying, I understand what we can do in this country now. We can take this program that has basically been a shell of what it could be, because there was a program that came in from another country, was doing the program for the Liberians, so that when the program decided to pull its funding and leave, Liberia was left with no ability to take the program forward, because there had been no sort of transfer of this program, and it had never been Liberian owned. She said, we can turn this program from a certificate, which is sort of a lowball training program, to a full-on degree program. And we can train the future nurse anesthetists for this country. It's going to take two things, time and support. So Mary is going to help put in the time, and Seed is going to commit to trying to help put in the time. And we're going to commit to trying to find the support so that we can actually grow this program into what Liberia deserves, and grow a generation of Liberian nurse anesthetists who will be able to help provide a path for safe surgery in the country going forward. But it's an uphill battle because, oops, I did some weird thing. Sometimes we're just swimming upstream in a way that we don't want to admit. So this is Anna McDonald. She's a family medicine doctor working in rural Malawi. And she's in her second year now. And Anna told a story at our close of service about where she had taught everybody how to take vital signs accurately on a timely basis, how to respond to those vital signs. So if a baby is having trouble breathing and the respiratory rate goes up, you increase the respiratory support for the child. So they actually had the baby on a breathing machine that was giving the baby support, and she was so excited. This was how it was supposed to work. And they're taking the vital signs, and then this happens. The power went out. The machine turns off, and I don't know if you can see on the far right, but the vital signs basically are the baby is blue, which is code for dead. And the punchline to this story that was so painful to hear was Anna said, and then I left the hospital, and I went home, and I got to turn on my lights. These are really real challenges that are bigger sometimes than the work that we're doing. But what I can say that Seed is committed to is asking the questions, raising a generation of well-trained doctors, nurses, midwives who can be advocates and agents of change for their own country, and we're going to support helping them do that. And we are on a multi-year premise. But that's the beauty of what we're going to do, because my hope is in 20 years, we're going to have a generation and a generation below that, and we're all going to be able to stand in solidarity and say, this is what we have started to change. But the story is just beginning. So with that, I want to acknowledge the many partners and people who make this work possible. And just thank you for your time, and I look forward to the conversation.
So it's interesting you mentioned this last issue of the power failure, and how everything that you believe in and everything that you're doing there, it just goes, right? And that made me think about how you took us in this journey from having the knowledge that you had, having an idea that was unique and important to follow, and how you got to Washington and talk about it, develop this wonderful program, partner with others, and are looking at the impact. And you were like laser determined to go in that path. And what were the ingredients of that journey that in you that created the passion for saying, nothing is going to stop me from where I want to get?
Does not feel that way every day, but I was very, very privileged to grow up the child of two public servants. One much better known, and one lesser known, which was my mother, who was an advocate for depression and raising awareness about depression in the late 80s at a time when nobody would talk about it. And to see her courage as a single mother growing up in a not the most overwhelming sort of community, overwhelmingly accepting community of single women as well, but to really just lead by example for my sister and me, and to also talk about something so stigmatized that nobody wanted to talk about, was an extraordinary gift. And my mother also made very hard choices in her life, throughout her life, that were very courageous, that were incredible examples for my sister and me as well, about being who you are, believing in who you are, and not necessarily worrying about overall acceptance. And I think that it was really, those were very empowering. I also had a father who was very publicly a public servant, and but it was the private moments that counted for me, whether it was his defense of me in what seemed like mundane moments, which were, I remember I played hockey in high school, ice hockey, and I remember we went to get me hockey gear, and the guy in the store sort of suggested I get a lesser product. And my dad went nuts on this guy and just said, my daughter is first line. And I just stood there being like, this is so cool. That was also very empowering. And I think that he also taught me a lot of lessons through his work, because I was allowed to travel with him and to see him in action. And there were really, really private moments that was just him and me at 12 at night on an airplane flying back from a campaign event, where I am embarrassed to say I whined to him about somebody needing something from me. And he very gently, it was chastising, but he very gently said to me, Vanessa, you never turn your back on somebody in need. And to have that from your dad when it's just the two of you is really profound. And I've always, always held on to that. And he's also taught me to be a constant optimist, because when he has been knocked down a lot and has gotten right back up and kept fighting, and has really believed that you can achieve peace in the Middle East, you can get an Iran deal, you can change, you can do global climate change, you can achieve these things that we think are insurmountable. He may not have achieved them, but he has continued on that fight. And those have been really extraordinary gifts. And I am very, very lucky to have those, because that has certainly made me believe that there's a path forward. And now today I'm lucky because I am surrounded by colleagues and this team at Seed and the team on the ground where we work who share that. So when one of us is down, somebody else is up, and we just carry each other forward. And that's been a really extraordinary gift too. And I am so privileged by the people that I work with and the people that I work for, which I think are our partners in the country, because they want something better. So it makes it easy to demand something different when you know what you're fighting for.
Yeah. This is really wonderful to hear about the role modeling, right? When we are thinking about our students or us as professionals, we're always looking, mentoring and mentoring, being mentors and mentees of many people around us. And certainly our role models are helping us shape some of the interests that we have. And what a better way of having those role models be your own parents, obviously. And that's wonderful. In thinking about being an entrepreneur and how you very systematically got where you are now and where you plan to be, which is pretty amazing, there are many obstacles that you face. Everything from funding to everything else that you can think of, and the unthinkable. What would be you talk about optimism, you talk about role modeling, you talk about being together with the people that you work with and helping one another getting through. But there has to be something within the individual that creates that, not pun intended, seed, right?
That's why we're called what we're called. No, it's a great.
That you nurture and that you make it flourish. And it has to come within, and believing in you is one thing, but and the courage as well, but it takes more than that, I would say.
I'm trying to.
Can you think of what it is as an entrepreneur that for the students here, for the professionals here that like you, like myself, are thinking, what else can I do that will be impactful, training new generations of professionals, etc. What is that?
So I think I think a couple things have sort of served me well. I think one has been the willingness to be flexible. So I think in the sense that you may come in with a set idea of what you want, and it is important to be focused on that. But I would say I would be focused on maybe a concept or a, because it may not always happen the way you exactly want. And I think the importance is, can you work with the reality of what is unmovable to reshape something, to repurpose, to redesign, to find the other path forward? And I think that we've had examples of that. I mean, for example, we thought when we started Seed, the government would just do the program, and then they said, well, we have no mechanism to do loan repayments. We said, okay, we'll raise that. The government said they won't send volunteers that have children because they don't want to be responsible for what happens to the children. And Seed said, okay, we'll do that too. I mean, I think it's a question of just finding some flexibility. And I think that if you can stay focused on what the common ground or motivation is, what the end game is, you may need to be flexible about how you get there. But I think having that a little bit of humility and having that ability to step back is very important, because that's where I think you're able to keep going. Because it's not been a perfect, seamless path that I have perfected along the way by any means. I think it's been a willingness to say, okay, back to the drawing board. And I think, an example right now, too, is that we could very well lose our federal funding. I think the global health space is going to contract majorly under this administration. And I don't know what it's going to look like. But what I do know is our work is important. I know our partners appreciate it. I know it is needed, and I know there's a way to do it. And our job now is to think through what that looks like and to be flexible in what that looks like, knowing that the end game is to train healthcare professionals and to build this capacity in country. But I think, we could be partnering with academic centers. So that's, I think, something that is, I think, also sort of very important in sort of the entrepreneurial spirit. And I think the final thing that is really, really important, and I think is very difficult to do, is to embrace the opportunity to fail. Because it is from failure, and how we respond to failure and how we recover from failure, as horrible and deep and dark as it is, that we find out who we are, and we actually sort of find, I think, in how you manage that will prove a lot to other people about what a program can do. And so there's always the expression of a phoenix rising from the ashes. And I think it is really important. And so sometimes when things are feeling crazy and going in the wrong direction, I go to the dark place, which is, if this totally goes south, what happens? And going there allows me to be free to actually then say, I just get a little scrappier and we figure our way out. But I think that's really important. And you may fail, but those failures are the places that I think you really figure out, what matters. And it's hard to do. I won't say it's not.
You've mentioned very important keywords that I actually wrote down, but one of them is you come back to diversity at all levels. Diversity of people, of resources, of thinking, of approaches. And I'm originally from Guatemala, and that's one of the countries that is in the red in your map over there. And someone who has gone out from the country and keeps coming back. We actually, my brothers and I have a foundation in Guatemala, and we do education there as a way to come back to our roots. But indeed, diversity is something that, as we talk about it in an institution, and being inclusive and embracing the diversity is very different than the diversity you're talking about. So I want to understand a little more about how do you make diversity be a catalyst, where it seems that diversity is, in many ways, it just shows differences and how to address differences rather than bringing people together?
This is a really tricky question. Because diversity, in its most fundamental sense, is also a difference in culture, I think, in many ways. And it is not just culture across international borders, culture across race or ethnicity. It's a culture of socioeconomic experience, of educational background, of values of exposure. And I think all those things can go into a successful program. And I think the key is that you have to listen. And I think you have to, I think that I have learned a lot. So there are members of my team who will tell you that I have a tendency to get really excited and jump in. And someone's in mid-sentence, and I'll be like, oh yeah, and a couple of members of my team are trying to really teach me to just stop and sit back and just listen and let people kind of finish the sentence rather than imposing what I think the end of the sentence is. And it's a really important skill that I am working on, because I find that what comes in the second half of every sentence is actually really powerful and really different than what I expected. And there's a lot to be learned. And so I think that, especially in the work that we do, there's a long history of American programs going to work in these countries and saying, this is what you should do. This is the right thing to do. This is what a good education looks like. This is how you build a building. And I can tell you a number of stories where that just fails. We impose our curriculum. They're not going to adopt our curriculum because it's not appropriate to where they work and what they do. So sometimes, even if it doesn't feel like the right thing to do, it's not gelling with what is kind of expected, and sometimes you got to just give it a chance and see where it goes, and you're going to be really surprised. But I think kind of having that patience and that trust isn't always there. But I think it's a matter of really, so for me, that's sort of where diversity can become a catalyst. It's as much on the person presenting as the person sort of receiving. It's much on the person receiving as the person presenting to be a part of that solution. And it's not a comfortable space because we know what we know. And, talking about this election, I gave a talk at the Fletcher School for International Service right at the day after the election. And somebody said to me, well, I've grown up all around this country, and I know this country really well, and no one I knew would ever vote for Trump. And even in Kansas, you're going to find the few people, I said to her, that, you know and like and gravitate with your values because that's what you're comfortable with and you want to be surrounded by. But the one thing that I got in 2004 that was so amazing was that even though I was on a running, traveling this country, technically being at Democratic events, I still found myself at 105-degree heat on black tarmac arguing with somebody who had spent all day waiting for a tour bus to come through about whether or not they were going to have their health care preserved. And I learned a lot in that 20-minute argument in 105-degree heat because I was exposed to what the wants and needs and desires and motivations of this person were. And if I really took the step back, it's no different than mine. Wants their family taken care of, wants to know there's opportunity, wants to know that they're going to be happy and healthy and have a job. We all want that, right? How we come at it is where the difference is. And sometimes if you can take that step back and find that common motivation too, you're better able to hear the path forward and to be able to embrace that diversity and hear the idea. I don't know, that's just my theory, but I don't know if it's, I'm notoriously wrong about these things, so.
Well, you've been pretty successful, I think, with what you've done, but as educators and you in the hospital and with your initiative and us here, certainly, in the university, we think about training the new generations of professionals that can think outside the box, right? That can think about all these things that are not taught in school. Are we doing a good job as educators in the system the way it is? Do we need to challenge it more? Northeastern University brings experiential learning, which is unique and a model used now by many others, but allows us for our students to be locally, nationally, internationally, globally exposed to all of this. But is there something else we could be doing in the classroom, or that we could be doing with the interaction with our students that opens that little window to be an entrepreneur and innovator, to be thinking that, no, you don't have to just be in an outpatient clinic and this is what you're supposed to be doing?
This is way above my pay grade. I think a couple things. I think we have to accept that the way we receive information now, and I think a lot of places are already doing this, the way we receive and process information is very different than the way we used to. And we are much more readily used to having the answer come to us very quickly. The internet, Google, Siri has sort of killed the creative process of research in some ways. And so it's a skill that I think needs to be very much encouraged, and so does critical thinking need to be taught. How you do that, I'm not sure I know that expertise as well. I think experiential learning, I do think, is incredibly important. I'm a physician. I trained in that. That's how I understood how to apply my knowledge, was to put it into different scenarios and to test it and to see what the response was. And so I think there's great validity. It's also active. And so in a time where our attention span is being increasingly limited by this influx of technology and the speed with which we get answers, I think keeping people active in the learning process is also going to be very important. And I think it's always going to be dynamic, because we are always going to be shifting as a society and a culture. And so, but I'm not sure I know so much sort of what we should do. I do think it is critically important that we do keep people critically thinking. And I think it is very, very important to instill a sense in all we do in education of sort of not for oneself. Because the one thing I will say that I've seen that is phenomenal in medicine, and I'm probably going to get in trouble for saying this, but I mean, the degree of narcissism of the learner in getting an education now is outstanding to me. And I still pride myself, and maybe I'm sure the people who trained me were like, and what's her deal? You know, I'm sure I was already, but I feel like I still grew up in a training period where I was very humbled by the privilege of taking care of patients, humbled by the amount I didn't know, and humbled by the opportunity to be a part of a system. And so when someone told me to do something, you know, unless it was like morally wrong or harmful, I did it, right? There was trust and faith in that hierarchy to some degree. I do not see that now. I mean, I have had people be like, well, it's 8 o'clock, my hours are up. And I'm thinking, you're halfway through a procedure on a patient. Like, where is your... And I don't know how to shift that. I unfortunately just had to miss the seminar on teaching the millennial, and I really wanted to go. And this isn't a knock. I don't say it's... I think there is something much larger and cultural that we need to be dealing with. And I, again, above my pay grade, I just recognize it and would love someone to help me understand.
This has been incredible, really. My goodness. A round of applause. Thanks to you, Vanessa. This has been wonderful. We may have some questions from the audience.
Yeah.
Step up to the microphone.
I think or I can repeat the question too if it's easier.
And we have people listening to us too that I don't know if they will have questions.
That's right. Hi.
How do you deal with political and economic risk in making decisions on which countries to go into?
It's a great question. So when we went to, part of the reason we chose our original 3 countries was we felt they were stable enough that we, could have a long-term presence in the countries. And to be fair, the countries that we've gone to, we've really gone to because they at least have physical security for the countries, which is a little bit different than economic or political. And there is a spectrum. All the countries that we're working in do not have economic stability by definition. So I can't really say that that exists. And that's a great challenge for us because as we're hiring people, as we're training people, we want to know that they can be hired. And in the case of Uganda, healthcare workers haven't been paid in 4 months. In the case of Malawi, they don't have a budget to hire new people. So we see part of our job as we get in this space and we train people. If we can show that there's cadre of high-trained people and we can get teams in country that can start to advocate for funding, we want to try to be part of this global conversation to help think this through. And part of it is also going to be talking to ministers of finance, and trying to be engaged in this bigger conversation. In some cases, we are thinking about ways to get funders to bridge salaries while we try to create this value premise. I personally have now been trying to work with the World Economic Forum on changing a conversation around health to really help people understand that investments in health are investment in economic growth and stability, and to try to find, coalesce some of the data around that as well. And so I think that is where we have tried to, make some kind of, it's not a perfect system, and this is our great unknown. We tolerate that because you have to start somewhere. And we also believe that if you create a generation of well-trained people who know what is possible, they also become advocates and agents of change. And this is a theory of change that I can't promise you is going to work out. We'll see in 5 or 10 years. But again, we believe it's the right thing to do. And that the paucity of skilled health professionals is the reason that Ebola happened at the scope and scale that it did in West Africa, because there was no one there to recognize it, advocate for help, and to help sort of be a part of the strategy and response. And that's sort of the space that we're working in. I mean, I think, it's uncomfortable, but if we start to show that we believe, so human resource for health has traditionally been the impossible task. And we think we're starting to show that it's possible at the same way that we then think that, that begins to create a shift as for every action, there's a reaction. And we think we can create a positive reaction, but I won't pretend we've got that nailed at all. Tolerating uncertainty is a very important skill I'm learning, no more so than today. Other questions? So we've solved everything. This is great.
So while people think, yeah, please, yeah, come here, please.
And if you don't want to get up to the microphone, I can repeat the
Yes.
question for people. So if the microphone is the intimidator, I'm good with that too.
Hi Vanessa, my name is Nuhia. I'm a student at the College of Engineering and I'm a software engineer. So this is the first time I have, sat in a conversation. I've got to hear something like this and it's very interesting. And so I was just wondering, technology is, everywhere. It's impacting us in, different ways. So how would you think in this purpose technology could, make it better, make it easier? Like, how as software engineers, we could help you.
Yeah, no, it's a great question. So it's very interesting. I mean, Eileen and I just had a meeting today about how we could appropriately use technology to support our mission. And so technology can be very powerful. We have handheld ultrasounds now at many of our sites that our nurses, midwives, and doctors are using, which means that you can see in real time what is going on in the body. You can teach really well because suddenly you can see things. You can help manage patients better. That is very powerful technology, and it fits in my white coat pocket. We have technology platform now that we have used to design a course to help our volunteers before they go do a lot of education and training on the pedagogy of being an educator so they can be more effective when they hit the ground. And that platform means that our volunteers that come from all around the United States can all join together in an e-classroom and be a part of this. And that is a very powerful engineer. Telemedicine can be very powerful as long as you have people you trust on the ground to translate, because you can never replace the physical exam. I cannot stress that enough. But it can be powerful for pathology, slide diagnosis, radiology, being able to see in real time and help to, understand what, and to, what is the word? I am tired. To actually read the read the CT scan or the X-ray and to be able to provide the diagnosis and the final report can be very powerful. But it's only as good to some degree as the infrastructure that supports it. So we talked about this amazing e-learning platform today. Wouldn't it be great if you could bring everybody together to talk about a case and you could do a simulation and everyone's in the community talking? It would be awesome if there was internet at any of our sites that was reliable, or a power generator that wanted to stay on. It's really difficult if you don't have some of these fundamental infrastructure tools to do the work that we do. And that's that's the power failure. That's the swimming upstream. So the degree that some of this stuff can become accessible, not reliable on broadband, very powerful. If there are tools that we can use that put in some like best practice algorithms would be really powerful. So if the ultrasound can read and can interpret with some decency and accuracy, heart rate greater than 50, or no, that's actually good. A heart rate less than 50, it would be, that's a problem, and help provide some decision algorithms, that can be really powerful. But we have to remember also that technology needs to be used responsibly and with people who can recognize when technology goes awry. And so it can't also be seen as the panacea. I keep seeing people be like, we're going to set up a telephone booth and you're going to go in and you're going to say what happens and you're going to some tests, it's not the perfect answer. And certainly with what we do, the place that we've provided the most value has been clinical mentorship in the hospital, because many of our trainees have knowledge, but they don't know what to do with that knowledge necessarily when you put the patient in front of them. And you really need a person to help you critically think through that situation in real time. But we need you. We need technology because you can help amplify, you can help simplify, you can help support. And so there's critical need for technology. I'm just always an advocate of hooking it to people. And the internet everywhere. Go Mark Zuckerberg.
So, since education is a major part of the program, so could you tell me if you could think of one simple thing that technology could do? One very simple step. What could it be?
One very simple.
Which is also critical.
That is, I mean,
Would at least create a certain impact.
would have an impact that technology can do. I think that if there were an ability to, I mean, there's infinite examples. I think if we could build, and this is just the example that we had today, if you could build a sim lab that is based on electronic decision making, like a choose your own adventure type thing. We have this in this country, but to make it more accessible, less power hungry, meaning not needing as much power to run it, not internet dependent necessarily, and not breakable, because this is the big thing. Things break and you can't fix it. So it's very, very sort of reliable and hardy. That could be, you could do actual trainings on, and really show that you're not always reliant on the patient, but you could do it in a more classroom setting, would probably augment some of the educational experience in a very, very real way. Eileen, help me think of things. We think about this all the time. And I think that is one very great example. If there were the ability to stand up an intranet within the hospital and the community so that there could be discussions and that is maybe done through mobile technology, would be very powerful. So that suddenly, you are able to communicate to people who are working in a community health center, but you could answer real decisions, or provide that kind of backup support. But in something that is available to many people, if they were to go to the computer, they could re-look up the images or have access to that information, would be incredibly powerful. I think the ability to communicate, a lot of it's around communication. A lot of it is around also, I think, diagnosis and decision making. But the problem, and so technology is powerful, but again, we need the medication. I need the central lines to put into patients in the hospital. I need the blood pressure cuffs to take the vital signs. I need the ability for nurses to feel empowered that when they see a patient that hasn't eaten in a week, they can make the decision to feed the patient post-surgically, that they don't have to wait for the doctor to do it. Those are some of the really fundamental. So I'm not trying to belittle technology, just all these things come together. And so, I'd have to, but I think that would be, I don't know, that's not simple, but it's powerful. That ability to train people on that kind of technology would be really profound, but it needs to be simplified. Yeah.
I'm going to ask.
Thank you.
Thank you. I'm going to, perhaps you'll repeat. Dr. Carey, I learned a great deal, so thank you so much. It was just wonderful. My question is, in the spirit of education and what we're doing this evening, in addition to the great work that you're doing at SEED, what other 1-2 nonprofits come to mind that you're, I want to say benchmark, but you're equally proud of, that perhaps we don't know about, that you would like to elevate or illuminate, to say we ought to be aware of the great work you're doing? I learned a great deal about what you're doing this evening, and it's absolutely tremendous, and it makes me more curious. Are you partnering? Are there other folks that or nonprofits that, before we adjourn this evening, we should be aware of?
So the question was, what are the 1 or 2 nonprofits that are also doing really outstanding work that maybe we should be aware of and know that are out there? So one that is not in the health space, but I just love this idea and I think it's really important, is called Global Citizen Year, and Abby Fallick runs it out of San Francisco. And it's the idea that before you go to college, you should take a service year. And that service year better prepares you for college, makes you more mature, better able to take advantage of that education, but you're also giving back to your community. And I am a big service person. And so that idea of service, I think, should be incorporated into the fabric of everything we do in this country at every stage. And so I really think that that's just another example of engaging in service. And it's a little more accessible than, say, having to be a nurse or a doctor or a midwife, but it's along the same veins of what we do. And you spend a year abroad, so you're also involved in your community and engaged in sort of, and involved in representing your country as well, which I think is incredibly important at this time and sort of day and age. I think that, when I think there's a lot of nonprofits, obviously, that are sort of involved and or working in our space. And I think that one of the, and I'm trying to, if I had to only pick one other, I'm trying to think what I would necessarily focus on. I think one that is going to be really important right now that you may know about, but I would really ask people to sort of get behind and think about it, is also Every Mother Counts. So Every Mother Counts focuses on basically safe maternal health. And they're really an advocacy group that is trying to highlight this. And the reason I raise them in particular right now is I think their agenda is going to be very, very compromised by what's happening in the current administration. And I think the jury's out on this administration. I don't know. Let's see what the cabinet takes shape. And I wouldn't even react to the names getting thrown out there. I'd see who actually goes up, because some of the names going out there are never going to be approved. And so I think we just need to be realistic that, we just don't know what this is going to be. And I will continue to hold hope, and I will continue to hope that he decides to be a president that represents the entire country, if he's going to be this healer that he says. And so I will hold my breath, but I will hope. But I think the one thing we can be sure of is that it is not going to be a very women's health focused administration or supportive administration. The vice president has very actively initiated some very troublesome policies in Indiana that I think are problematic. And I think you're going to see that both on a domestic and a global agenda carry forward. And President-elect Trump himself has said he's going to pick a Supreme Court nominee who is pro-life. So the work of Every Mother Counts, I think, is going to be incredibly important. They're both domestic and international. And I think Planned Parenthood, everybody knows, but I would just, and there, thank God, people are really rallying behind them right now, and I'm grateful for that as well. But but I think Every Mother, so that would be the second one that I would just sort of add right now. And, we're all in this together. We are a global community, so whether we are focusing on gap years, or whether we are focusing on women's health, or whether we are focusing on, food security or education, or Indian health services here, we are part of a global community that is sending a message that there needs to be better equity, that in 2016 there should not be the disparities that exist in the world. And I ask everybody in this room to be a part of that fabric in whatever they choose to do.
Wonderful. Thank you, everybody.